disclosure, we have nothing to disclose other than the fact that we are not MDs, okay? Everybody else has presented that's pretty much been an MD. We are not. We're just nurses trying to survive COVID and everything else with infection control. So you're going to be the drive-by clicker. Okay. So go ahead, Kristi. So, that's exactly right. Thank you. So one of the questions that we had is, how many of you guys out there are IPs? Oh, there's quite a few of you guys. Whoop, whoop, good job. Been beat up through COVID, I'm sure, as we all have. But during Dr. Gabani's talk, she did talk about the core elements of a very good antimicrobial stewardship program, which I'm just going to say ASP or AS because it's a lot easier than just putting all that out there. But we thought it would be important to put up the core elements and then what our role was with trying to meet some of those core elements as we go through, and kind of our day-to-day jobs within antimicrobial stewardship. And a lot of it is surveillance, as you guys know, and that's what the emphasis of this talk is going to kind of be about. So take it away, Kristi.
Oops. I can't even run the clicker, so there we go. Stay up here. So I think, you know what, as Sharon already said, we've all lived through the last 2.5 years as infection preventionists, and I work in post-acute in a facility that has both hospital licensure and nursing home licensure. So we follow kind of a little bit of both on both sides. And so it's been quite a couple years. And I think all of us can relate to the fact that, all of the IPs in the room especially, that this has been a full-time job for 2.5 years doing COVID. And in addition to our already busy full-time jobs. And many of us in post-acute settings, and even in some of the hospital settings, do more than one job. And now we added COVID to that. And so antibiotic stewardship kind of slipped by the wayside, didn't it? When we were just getting started, you know, trying to get going in our programs and stuff, and then we got kind of blasted out of the water. So when Sharon and I were talking, we felt, you know, it was really important to really go back and look at the core elements and make sure that, you know, it is a great structure to a program. And so I think we need to make sure that we talk about it and utilize it, especially if you're new to IP and you don't really know what your program's like. It's a good way to go back and check to see, you know, how you're doing in your facility.
So what we do know is that antibiotics save lives, and they make our world a lot better. But there's also collateral damage that can occur, especially with the multi-drug resistances. And so, you know, CMS or CDC, they always have to step in and make sure that we toe the line, like with your water management plans or whatever. So that's why they came up with a toolkit or a guidance that you can download, and it's for hospitals, outpatient, resource-limited settings, nursing homes, and there's actually guidance for critical access hospitals. So my responsibility within the facilities, as I'm sure Kristi's is to lead organizational initiatives that prevent and control healthcare-associated infections. And increasingly, we need to be more active in antimicrobial stewardship. And we need to be active members on our committees and on those team meetings that we have. Unfortunately, within the CDC guidelines, there's no real definitive role. It doesn't really tell us what our role is. Trust me, I Googled it. I went out. What is the IP's role in antimicrobial stewardship? Well, it just gives me the core elements. And so when you're looking for, you know, how do you identify? How do you know what you're supposed to do for antimicrobial stewardship? It's really more of a supporting role and working with your pharmacists and working collaboratively to get the data that you need and make sure that what you're finding and that what you're seeing, you're able to do action plans and move forward on that. APIC actually surveyed infection preventionists in 2018, and they found out that only about 28% of all practicing infection preventionists actually sat on their antimicrobial stewardship committees, and so that's not very many. So if you're not on your antimicrobial stewardship committee, you need to ask to sit in on that and weigh in on that and be part of that. And only 18% of the infection preventionists that were actually surveyed actually felt that they knew what their role was. And obviously, I was not in that 18% because I did not know exactly. And I tried to look it up, but I couldn't find it, so.
Yeah, and I think too, you know, as we, I have to figure out how to run the clicker.
The clicker?
As we move through this, you know, we wanted to, in long-term care, I think, you know, our role in long-term care is definitely what Sharon said, supportive. You know, we really can't be expected, and I'm just going to be on a soapbox for a second, to take on the entire responsibility for that antibiotic stewardship program. We need to be part of it. We definitely need to be at the table. We need to be supportive in data collection and surveillance and bringing that information to the group. But to run the committee, it's just not possible in many of the facilities, and I don't know as though it's necessarily the IP's job. I think it belongs to, you know, the structure that's put in place by the leadership, but definitely a physician, pharmacist, even your lab, if you can get somebody from the lab there, because most of us use labs off-site. And so we want to make sure that when you're looking at those core elements, we're going to talk about a little bit about each one of them. But you know, I think about nursing homes, and I know CDC says that at least 70% of residents in our nursing homes have been on at least one course of antibiotics in a year, some of them more than that. We all know that probably happens. And so out of those 70%, and I know there's similar studies in hospital settings as well, out of those 70% of those residents, 40 to 75% of those antibiotics that are being used are unnecessary. And so that's a little scary, because if you're like some of us, and I'm thinking about my facility where we have in our skilled nursing facility about a 25 or so bed ventilator unit. We also have probably another, I don't know, Jody works there too, but maybe another 10 to 15 residents in the nursing home area that also have trachs. And so we have a huge risk for our residents to continue to be on antibiotics for different reasons because of the devices that they have. And then we're staring down the face of the enhanced barrier precautions. Everybody's heard about that. And so we have to do something about the overuse of antibiotics in nursing homes, because we can't continue to have some of our residents growing these really resistant organisms. It's making so much more work for us. And so that's why it's important for us to be part of it and bring that data back to the group to say, look, we have these issues. And so I think it's important for us to talk about how that works in these facilities so we don't cause more harm for our residents by giving them antibiotics.
So one would think that antimicrobial stewardship is just pharmacy alone, but it's not. It's part of our job as well. And my part of antimicrobial stewardship, I feel, is the surveillance part. Looking at the active cultures and trying to look to see if they're on the appropriate therapy. We found in our facility that we're critical access, and so about 70 to 80% of all of our positive cultures dropped in after the patient was out of our facility. Where does that go? It went to the gremlin somewhere, because doctors weren't getting it, facilities that they came from weren't getting it. So we had to look at how we're going to do more concurrent surveillance. And one of my pharmacists is actually sitting in the room today, and her and another one of our pharmacists at the hospital, we work very closely together, and they've taken on part of my job as surveillance, in that they look at every single inpatient and ER patient to make sure that that patient is on the appropriate antibiotic. If not, we have a lifeline that we can call, and I'll talk about it a little bit later, but it's UNMC. We've partnered with them, and we can get direction. And then my part of the job is to do all the other cultures. So we call doctors, we call nursing homes, we reach out and make sure that the results were there, and if they're not, then we send them out, because we can do the cultures, but if we can't get a doctor to see them, we can't prescribe, and we need to make sure that we're prescribing for actual infections as well. So.
Go ahead. Leadership.
Oh, leadership, I guess I'm again. So in order to have a really robust ASP, you have to have backing from leadership, obviously. And I have to say that we're very unique at our hospital in that we have awesome backing. Our pharmacy director is a phenom. When he came on board, I'm thinking, dude, I don't think that you've shaved yet because he was so young. But he's young, he's intelligent, he's very articulate. He can talk to anybody on a level that they understand. He's got the respect of our providers. And so when I first I had seen some surveillance on board, and he's like, yeah, Sharon, antimicrobial stewardship, I don't have time for that because we were doing all this other stuff. Well, then it came up, and he had to kind of pay attention to it. But he lobbied to our leaders to be able to put on more pharmacists, because to do the data mining for the antibiotic utilization, that's a daunting task. If you don't have software that will mine that for you, they were spending hours and hours and hours, and we need to do patient care as well. So they brought on extra pharmacists to help us do that, and I think that Lori is part of that as well. And then when you're looking at technology, we have a hybrid beta program at our facility that it's a great place to park data, but to get data out of that, it's painful. And then when you look at reporting to NHSN, you hear that a lot. You need to report to NHSN because, the data, Nebraska's not looking very good. We had no way, even if we could mine the data, we didn't have a platform in order to insert that data into NHSN. So I was really glad when Dr. Ashra, I don't know if I said your name correctly, said that there's funding out there that if you need to look at software programs, that there's some additional funding, but we ended up having to get additional software, and it was costly, but our administration felt that what we were trying to do with antibiotic stewardship is meaningful, and and at the end of the day, it's going to affect patient care. And we're going to be a lot better moving forward. So, they cut loose the purse strings, and they made that happen for us, which I was really, really happy about. They give us autonomy to work within our scope of practice and do the jobs that we need to do, which is really awesome. And I think that Kristi's going to talk a little bit. You need that first and foremost. And that was our first thing that we needed to do. We needed to get administration on board. And they actually had to sign a paper that they were going to back us in what we needed to do for our antimicrobial stewardship efforts.
And I think in the nursing facilities, we really need to rely on our leadership, our administrators. If you're part of a corporation or ownership, something like that, we have to have the backing for infection prevention. We all know, everybody that does infection prevention, especially in a nursing home, that the requirements of our job have grown so much in the last couple years, not just with surveillance and everything with COVID, but all of the reporting and everything that we're doing. It is unbelievable what we were being asked to do. And we even, I even have Jody helping me, Jody's son, with infection prevention, and it's still, 70-hour job a week in some weeks. And so we have to have leadership who's going to see the priority in infection prevention and support us in the time that we need to spend. We can't keep taking on more jobs. We have to do what we have to do. And so I think it's important for that to happen. The other thing that leadership can help with in the nursing home is that, we have a lot of family members that have opinions about how residents should be treated. And I don't mean to joke because, my parents were in an assisted living and stuff as well. But we called it at one point Dr. Family, because they seem to want to have an antibiotic for this and get a UA for that, and any of those different types of symptoms that they feel need to be treated with an antibiotic. And some family members can be pretty persistent about it, and I think some of you I see some heads nodding. So I think it's important for leadership in your facility, whether that's the administrator or director of nursing, to be able to go to resident council meetings, to send out written communication about antibiotic stewardship. Why do we feel it's so important? And why do we want to make sure that our residents aren't over-treated with antibiotics, and what the risks of that could be, and how that could harm our residents instead of help them? And so it's important for our administrators to help us with that, directors of nursing to help us with that as well from a leadership perspective. So accountability, I think, we've talked a little bit about that leadership piece, but I think there needs to be, you've got to identify that leader of your antibiotic stewardship program. And I think it's important for that leader to be somebody who's, like I said, trained in infection prevention or infectious disease, something, that they have some background in it and understand the importance of it. And I think the medical director needs to be involved in your facilities. They need to be the person to set that standard for not only treatment standards, but how things are going to be prescribed, and then to monitor it and be able to address it with the providers that are coming into your facilities. When we do have a problem with somebody over-prescribing or something, they need to be willing to do that. And I think the directors of nursing in your facilities, on those committees, they should be on the committee as well, but they need to set that standard for your facility for the nursing staff to perform accurate assessments and know that if they have these symptoms, foul-smelling, dark, cloudy urine is not a UTI symptom. It's maybe dehydration. Maybe we need to increase some fluids or look at what they ate for lunch. Maybe that's what's causing the odor. But in any case, it has to come from that leadership on the antibiotic stewardship committees, and to talk about what are those symptoms, what do we want to do for education. And the director of nursing needs to set the standard for that assessment, and then how is that assessment communicated to the provider? Because lots of us don't have providers coming in to see these people. We're communicating to them about what we're seeing. And so I think it's important for those things to be set. And then of course our infection preventionists, when it comes to surveillance and stuff, you are accountable to make sure that you're looking at the lab results and making sure that you're looking at proper treatment, and then addressing that with some of the staff on the floor that need to be looking at those lab reports in addition to you. Sharon's talked about the pharmacists, and in most nursing homes, I think a lot of us are using consultant pharmacists, so they aren't on site. They're coming in and doing those med reviews, and it's a little bit difficult to get them involved sometimes in some of these committees. I think it's gotten better, and I'm glad to hear that we're going to be having some training or some support in nursing facilities for consulting pharmacists, and how can you have a piece of that antibiotic stewardship responsibility, because they are very important in that. And I don't want to forget about the lab, because like I said, a lot of us are using reference labs. They aren't on site, and so it's important to have them at the table. Somebody needs to be notifying, either they're giving you data or they're at the meeting, if you're lucky. Somebody would be there to represent the lab and be able to discuss what their role is in it, and also what can they give you. What can you get from them when it comes to antibiotic stewardship? And I think one of the big pieces in that with the labs is making sure, how are they notifying your facility when they see a really resistant organism come back on a culture report? How is that communicated to your facility so that we can do something about it right away as soon as possible, get them into precautions and whatever isolation needs to occur. So those kinds of things can help with that stewardship as well. So we want to make sure they're at the table. And then your local and state health departments can always help with resources for education and also testing and things like that that might need to occur.
So as a critical access hospital, we actually lacked being able to have a medical director that really wanted to step up and take on that role. We don't have an infectious disease doc to help guide us. But fortunately, we had already contracted with UNMC that they were already doing our positive cultures. So it was an easy question for us to ask, would you partner with us to step up? And Dr. Van is actually our director of our Antimicrobial Stewardship Committee because we've already partnered with them. And then Jeremy High, the Antimicrobial Stewardship pharmacist, and they zoom in on our meetings every month or whenever we have them. Honestly, we were one of the first people, I think, to partner with UNMC in antimicrobial stewardship. So even though you're a small facility and you don't think that you can meet some of the overarching requirements, you can. You just need to reach out and see where your sources are and see if you can contract. Those larger facilities that do have those ID docs are more than willing to talk with you and come up with something that is doable for your facilities, and I highly encourage you guys to check into that. They have been instrumental in helping us develop like our soft tissue algorithms, our urine culture algorithms, and our pneumonia order sets, because obviously those are part of the antimicrobial stewardship elements of performance that you have to meet. So it was easy for us to do that. We've also have 3 pharmacists that have become certified in antimicrobial stewardship, and we have nurses from our patient care area that actually sit on those committees and give us valuable input as well. So, okay. So as far as, at least at our hospital, we have 4 pharmacists. We are very, very fortunate to have that many for critical access. And they provide expertise in dosing and tapering antibiotics. They assist in writing algorithms. And they're all encouraged to get certified in antimicrobial stewardship. So I think that we have the expertise there. And I don't, it's hard, like Kristi said, because they have to contract out with consulting pharmacists. We have the ability to have those in our own facility. And I know that there's critical access hospitals down the road from us who do not have pharmacists on board. And maybe they aren't as far along in their antimicrobial stewardship program as we are. And it's unfortunate. They just don't realize that there's resources out there that they can contract with at probably a really reasonable cost in order to meet some of those elements of performance.
And I think, in nursing facilities, as I've already said, the consultant pharmacists need to be at the table with your stewardship program. And so if they aren't going to help lead it, it's important for them to at least be part of it. And I wanted to mention something else when it comes to pharmacists. And in our facility, our pharmacist helps develop the antibiogram. In fact, one of our clinical pharmacists pretty much does the whole thing. And we have to gather data from two different labs because we have the campus in Omaha and the campus in Lincoln. And so she's working with both of those. But I think one of the things with antibiograms, and I don't know how many in the room use antibiograms as part of their antibiotic stewardship. And if you don't, it's important to figure out, if there's a way that you can get one, get your hands on one and get one developed. But I always want to share that if you don't have one or you haven't been using one, I would encourage you to get in touch with the infection preventionists at any of your referral facilities, because they may have one and they hopefully will be willing to share that information with you, because you're getting your residents are coming from some of those facilities. So whatever they have at those facilities could help you in your facility if you don't have an antibiogram to utilize. And so, I know Sharon and I both belong to APIC, for example. I don't know how I would do my job if I didn't, because for a long time I was the only infection preventionist with Madonna. And so it was nice to go and visit with infection preventionists at our meetings and be in a room with people who understood what we do, because many times we're the only ones. And so, but by having a contact at your referral facilities who's an infection preventionist that you can call and talk to, whether you need that information about what any MDROs they might have, or looking at their antibiogram, and your leadership in your facility can help with getting that connection and that relationship going so that you can get that information and at least have some information about the bacteria that you're having, the things that are coming into your facility and the resistance patterns to those types of things that are coming with those patients that you're taking on, from those facilities. And it might be a way to get some information if you don't have an antibiogram that you can look at currently. Action. We got to take action. And I think that's probably the big thing, is just do something. If you aren't currently doing something, or you got sidetracked by COVID, we've got to get back on track and start looking at this, because it's pretty clear in the updated interpretive guidelines that it's part of infection prevention, and so we have to start looking at it. And I think audits are really important to do if you want to start someplace. I know at our facility, Jody's been collecting information on our nursing home by provider. And how many antibiotics has that provider been putting residents on, and what was the reason? Was it appropriate or not? So that we can give feedback back to the providers, so that they can see kind of how they're doing in their prescribing. And it's been helpful. We just unfortunately we start something and then we have a COVID surge and then we have to kind of get sidetracked again. So we're trying to get back on track with getting some of these things done. But take action, start somewhere. And I think one of the things that is helpful is And if you haven't used this, the core elements, I wanted to point this out, is that they have an assessment tool that you can use to do an evaluation of your program. And we actually look at this every year in our antibiotic stewardship, this checklist. There's one for nursing homes and one for hospitals. But it actually, I don't expect you to be able to read it. I just want to show you, it is actually a checklist, and it gives you some ideas on things that you could be doing, and you can check yes or no, or maybe, oh, let's work on this. But it's got some great ideas. If you're looking for something to do or a place to get started, or maybe a different track to take in antibiotic stewardship, look at that assessment tool. It's part of the CDC site for the core elements. But I would encourage you to look at that and use it as a way to evaluate your program on a regular basis.
So as Dr. Van knows, our pharmacy director, he's kind of a pit bull. I mean, he's after it, man. So he has taken this assessment tool and actually integrated into our quality measures. So we look at it like on a monthly basis at a quality meeting. And for our first year, we set our measures at 25% because we were trying to get all the paperwork and get a medical director, and it went pretty fast. And then the next year we set our goal at 50%, that we would meet 50% of the items in that assessment. And we set our goal then at 75%, and we stalled out at 75% because we couldn't report our usage. We couldn't report days of therapy. We couldn't report our resistance amounts. And it was really problematic. Moving forward, we just implemented a new software. I think we went active in March that is going to help extensively with the data mining. And as an IP, reporting into NHSN, that's an infection prevention reporting software, but there's also an antibiotic utilization section to that. So we will build that component next week when we get back, because we're to that point where we can pull that data now from our software, and we'll be able to start putting that stuff in. So every year, Anthony looks at that assessment to see what we've knocked out. He lets me look at it. Is there anything that you think that we've met? What we are falling short on, obviously, is patient ed and the provider ed. But infection prevention can truly be instrumental in helping with that education to patients, to staff, and I let Anthony do the doctors because he handles them a lot better. But I want you guys to remember that ASAP is out there for you. It's free of charge. Dr. Van came to our facility and did our stewardship assessment, and he used, I think, Anthony says, the form that they got from the CDC, and we got great recommendations, great guidance to be able to really beef up our antimicrobial stewardship program. And I want to just put a plug in for ICAP as well. There's an infection control component to Nebraska medicine that Kate Tyne came out to our facility with Margaret Drake and did a great assessment in our facility, gave us great feedback. And it's free. Why won't you do that just to see where you're at and help you, outside of your facility, because, we all think that we're doing great in our four walls, but, get some clean eyes on how you're doing and get some guidance that way. Sorry. Am I up again?
Well, and as far as tracking, that's a big part of our job with antibiotic stewardship. And I think the tracking being all of the surveillance that we're doing and the data collection that we do on a regular basis, it's key. And Sharon's mentioned data mining systems. I don't know how many people in the group here today or how many nursing homes actually have data mining systems. I know data mining systems at our facility is called Jody's son right now because we don't have one. We've wanted one for years. We spend a lot of time, paper and pencil and Excel spreadsheets, and it seems so wasteful of everyone's time. Data mining systems can help us, and I wish that we had a magic wand that we could say everybody gets to have one. But unfortunately, that doesn't always happen. But I think we have to look, I would encourage everybody that has EMRs, since a lot of us, I think almost everybody does now, EMR systems sometimes come with them. So I would encourage you to ask somebody that had something to do with getting that EMR in your facility, is there a system attached to that or something that could be purchased, and there might be some funds, it sounds like, to do something like that. could that go towards, a data mining system to help you with your job? Because we know we are so, pressed for time. And so I think I would encourage you to do that if you haven't already checked it out.
And so for us, it was probably a no-brainer because the amount of hours that our pharmacists were utilizing in order to try to extrapolate all the data that we needed, it's going to free our pharmacists up to go to the bedside. The software that we purchased, it's more infection control, but it has a complete pharmacy antimicrobial stewardship component on the other side of it, and it's going to let me go to the bedside. And obviously, there's going to be funds out there, maybe to help subsidize some of that. So
we're spending all your money.
Jump on that bandwagon for sure to see if there's something out there. It might just be that you need to turn something on, or you might need to just buy a little added piece to your software that you already have. But I do encourage you, like Kristi said, to go talk to your IS to see if you can get something turned on that will help you with your data mining.
And I think for surveillance too, with tracking, you want to make sure you're tracking things like new antibiotic starts, how many antibiotic days your residents have. But the other piece of that too is you need to track your MDROs in your facility. Who's coming in with them and how many are you're finding while you're there at your facility. Because you need to know that because it will help you with your monitoring your antibiotic stewardship as well, to know if you have those MDROs are going up or not. So. And then when it comes to reporting, I know we're getting close to lunch, so reporting, I'm reading and hearing about NHSN working on some plans for nursing homes to start reporting antibiotic use reporting, like the hospitals are. And everybody gets heartburn when we talk about NHSN, because we're all in there now because of COVID, right? They can start requiring us to do all kinds of stuff in the nursing home. And I keep saying, who's going to do that? Because we can't keep adding to what our IPs are doing in nursing homes without adding some resources, right? So we want to make sure we're looking at, it went off, that we're looking at how can we collect that information on antibiotic usage. So that's coming down, I think NHSN is going to start requiring that.
The other thing too, with our reporting, if you have the ability to pull your antibiograms, I highly encourage you to do that. With, all of our cultures go to Nebraska medicine, so we get a glomp of our whole area. But now with our new software, we're able to do a very specific demographic antibiogram and see exactly what our bugs are resistant to. We've actually changed doctors' practices when they saw that the antibiotic that they've used forever is not as effective against a particular organism, but you give them the Carfax. And so our director of pharmacy is ecstatic that we can be able to get that, because it is very meaningful data to use.
It's like the energy report for physicians. Sometimes it does help them to see, and we've even had a nurse practitioner in our facility has sent out, an email to the whole group saying, hey, I don't think this person has a wound infection. They don't really have any symptoms. I don't think we need to be treating them with an antibiotic. And I about went, oh my gosh, and I sent her a quick email back saying, thank you. This is great. So that feedback that she got has really got her thinking differently about, how she's prescribing.
So as far as education goes, that's really a lot of my job. Sorry, I'm trying to hurry because Kate gave us the one. Study shows that nurses often are unfamiliar.
It's us against food right now.
I know, it's us against food. And I'm surprised people aren't bolting. But study shows that nurses are really unfamiliar with antimicrobial stewardship and exactly what that means. And once we educate them, they'll be able to understand a little bit more about what we're trying to do within our committee. And so honestly, the biggest thing is like I want to keep on calling you Terry. Okay. What Kristi said was identifying colonization versus infection. A dirty, yucky smelling urine does not mean that it is infected. And I was finding on my surveillance that we were ordering urines on flipping everybody. You come in with a stroke, we're going to order a urine. You come in with a broken leg, we're going to order a urine. And why? And if it was positive, we were treating it, whether it was symptomatic or not. So we're learning, the doctors are learning, and we're being a lot better because of the antimicrobial stewardship that we're not putting on patients.
In the nursing facility, I always want to add with education, we have to include those frontline staff, because the nursing assistants know those residents, and I don't want you to bypass the EVS workers because they know those residents better than some of the rest of us. They spend time in the room, they know the favorite TV shows and all that kind of stuff. So we need to educate everybody on what does an infection, what are those symptoms of infection, especially the top three: urine, respiratory, and wound, although I would add in GI as well. But I think we need to make sure that everybody knows what those symptoms are so that we don't have a nursing assistant coming to the nurse and saying, you know, about the foul-smelling urine, increase fluids. There's things we can do for education. And I found it interesting that on the internet, on CDC website and also AHRQ, have great information about just education materials that are out there that you can use with family members, with residents, and with some of your staff as well. So I want to make sure that you know that stuff already exists. Just go out and look for it on those websites and start utilizing some of that information for your education.
So in summary,
Go for
I'll
it.
let you guys read the signs, but obviously, we need, as IPs, we need to be supporting accurate microbiology testing practices, making sure we're doing only the testing when it's necessary, ensure safe antibiotic administration process, make sure that we are definitely part of that education piece to the patients, to the public, to policymakers, and promote vaccines, go vaccines. Any questions? I didn't think so. Go ahead.